Thiazide diuretics. The thiazide are most widely used diuretics because of their antihypertensive effect. They are also called low ceiling diuretics because increasing dose above normal will not promote any further effect. Now, chlorothiazide, chlorothalidone, hydrochlorothiazide are all thiazide diuretics. Mechanism of action: the thiazide-like diuretics will mainly act in the distal convoluted tubule, and it will decrease the reabsorption of sodium by inhibiting the sodium chloride cotransporter. As a result, the concentration of sodium and chloride in the tubular fluid will increase, and the efficacy of thiazides may be diminished with use of NSAID, such as indomethacin, which inhibit the production of renal prostaglandins and reducing the renal blood flow. We can see here these are the diuretic classes and the urinary excretion. For thiazide, sodium, potassium, magnesium will be excreted, calcium will be excretion decreased, chloride will be excreted, not bicarbonate or uric acid. For loop diuretics, urine volume will be threefold increased, and sodium, potassium, magnesium and calcium also, chloride with uric acid. Aldosterone antagonist, in chronic it will be increase the sodium excretion, whereas here all are the same. Epithelial sodium channel antagonist, here also same effect as aldosterone antagonist, and these are potassium sparing, they spare potassium, they do not excrete them. Carbonic anhydrase inhibitors, also same effect, but they excrete bicarbonate and potassium. Now, decreased urinary calcium excretion, reduced peripheral vascular resistance. These are the actions. Now, therapeutic uses are hypertension, heart failure, hypercalciuria, diabetes insipidus, and pharmacokinetics. They are active orally 1 to 3 weeks to produce stable reduction in BP. Adverse effects are hypokalemia, hyperuricemia, hypotension, hyponatremia, hypercalcemia. You have to remember this for thiazide diuretics. Potassium, sodium are both hypo and calcium is hyper. Next is loop diuretics. Bumetanide, furosemide, torsemide, ethacrynic acid, they have their action on ascending limb of loop of Henle. Mechanism of action is inhibit the co-transport of sodium potassium chloride in the luminal membrane of the loop of Henle, therefore reabsorption of these ions is decreased. Actions is diuresis, increased urinary calcium excretion, venodilation, they cause acute venodilation and reduce the left ventricular filling. Therapeutic uses are edema, hypercalcemia, hyperkalemia, because it decreases and excretes calcium and potassium orally or parenterally, and 6 hours for duration of action. Effects: ototoxicity, hyperuricemia, hypotension, hypokalemia, hypomagnesemia, acute hypovolemia and hypokalemia, hypomagnesemia, ototoxicity and hyperuricemia are all these adverse effects. Then potassium sparing diuretics act in the collecting tubule to inhibit sodium reabsorption and potassium excretion. Aldosterone antagonists, spironolactone and eplerenone. The mechanism is it prevents translocation of the receptor complex into the nucleus of the target cell, ultimately resulting in the lack of intracellular proteins, stimulates sodium potassium exchange sites for collecting tubule. Actions include they cause diuresis and non-renal sites, which also have other effects. In edematous state, blood levels are high and it causes retention of sodium. Spironolactone antagonizes the activity of aldosterone and results in potassium and sodium excretion. Retention of potassium, so it spares potassium. Therapeutic uses are edema, hypokalemia because it spares potassium, heart failure at lower doses to prevent myocardial remodeling, resistant hypertension, polycystic ovary syndrome, this is used off label, and pharmacokinetic, well absorbed orally, P450 enzyme system. Adverse effects are hyperkalemia, gynecomastia, induces gynecomastia in 10% of the male. Then is triametrine amyloid. These block epithelial sodium channels, resulting in decrease in sodium potassium exchange, although they have potassium sparing diuretic action. Carbonic anhydrase inhibitor is acetazolamide. Often other use, they are less efficacious than thiazide or loop diuretics. Acetazolamide inhibits carbonic anhydrase located intracellularly, and it catalyzes the reaction of carbon dioxide and water, leading to H2CO3, which ionizes to proton and bicarbonate ions. Therapeutic uses are glaucoma, oral. This decreases the production of aqueous humor and reduces intraocular patients. Altitude sickness, used in the prophylaxis for altitude sickness. Pharmacokinetics, orally, IV, and adverse effects are mild metabolic acidosis, potassium depletion, renal stool formation. Osmotic diuretics. Now, filtered substances undergo little or no reabsorption, result in higher osmolarity of the tubular fluid. This prevents further water reabsorption in the descending loop of Henle and proximal convoluted tubule, resulting in osmotic diuresis with little additional sodium excretion, aqueresis, sodium excretion. Therefore, these agents are not useful in treating the condition where sodium retention occurs. Osmotic diuresis is a mainstay of patients with increased intracranial pressure. Mannitol is not absorbed when given orally and should be given IV. Dehydration, extracellular water expansion form osmotic effects, and this form and causes hyponatremia and until diuresis occurs.